Good afternoon, everybody. Thank you for joining us here at Healthmonics for another one of our great webinars regarding 2024 MIPS. Today, we're going to go over some tough measures. We're going to hear from our experts on some of the things that you should understand, as well as some of the things that are coming down the line. As of course, like normal, CMS is not making this any easier for us. So today I'm going to be joined by Tara Kalra and Josh Hall. I will get her name right on the first time one of these webinars. Hi, Tara, and hi, Josh.
Hello,
Hey,
everyone.
Mike.
All right. Just some housekeeping, handouts, and questions. You could ask questions right on here. Some may be difficult to answer back on in the webinar setting, but feel free to ask them, and we will try to get back to you within by the latest early next week. But ask your questions here. There may be some opportunity to answer some of them towards the end of the call. You'll find the handouts attached to the webinar. You can download those as well. And then by later this afternoon, you'll receive the full webinar and the handouts from me in an email. If you don't get them, please check your junk email. They may end up there. So without further ado, let's get started on this. Today we're going to review measures. Take a look at what is a MIPS measure and a short overview of what it means and some of the different aspects of the measures that you may not be very familiar with. Then we're going to look at some difficult measures. We're going to take a deep dive into some measures that are very popular right now, but aren't 100% understood by all of the MIPS users out there. And what should you be doing today? We'll finish off with some of the steps of preparing yourself for what the future looks like and give you the opportunity to ask your questions. So when it comes to the measure overview, I am going to throw this over to Josh Hall.
Sure. So, as we know, every year measures change. Um, there are so many reasons why a measure might change year to year. More often than not, it's simply because clinical evidence is updated or billing and medical coding is updated. So, year to year, different codes might come in or out, codes might get retired, so they naturally need to update the measures accordingly. Um, Usually, measures are pretty consistent year to year, but occasionally they do need to change some essential parts within a measure. Rather than getting rid of the measure, they might just update the clinical evidence as needed. Um, However, say a measure has gone through an extreme change, maybe there's a new measure out that's duplicative, or maybe they've discovered after a few years, hey, these two measures are too similar. We're not getting the results that we want to see. The CMS might completely get rid of the measure. Um, Measures can also be eliminated because they're topped out. A measure is topped out if the people that are reporting it, the providers, hospital networks, groups, um, if everyone's getting a really, really good score every single year, then it's not the data coming in isn't too valuable for CMS. If everyone's acing the test, well, maybe the test needs to be rewritten and the measure is time to be retired. So that's what when a measure might be eliminated if it's topped out. Um, the measures also change each year, and they often seem to become more challenging. Um, Measures are becoming more complicated. CMS wants, and measure designers and owners are trying to get more out of each measure. So thresholds and requirements are being raised. The scoring rules are being changed to reflect program goals. So the more goals you add, the more things that measures are graded against. They'll naturally be a little bit more complicated. And the types of measures that are coming out often seem to be a little bit more complex. So measures are trying to be focused more on outcomes and patients. You're going to be looking ahead at some measures and you'll see, oh, there's still a lot of process measures here. However, there are some patient-reported outcome measures that are coming in 2025. So these measures are really increasing in depth year to year. Um, so measures want to be outcome, We want to add new measures for that reason. And we're also trying to meet current healthcare initiatives. So we're going to see some new measures for 2024 that are doing that. We want to be able to align all of the different value-based programs in CMS. Also, as measures become retired, specialties need to be able to report on measures. So if you're a specialty and all of a sudden all the measures you used to report on are going away, that inventory simply needs to be refreshed. We need new insights into your specialty. We need new measures um, to work with. And finally, it increases the opportunity for specialists to participate in traditional MIPS and MVPs. So adding in a variety of different measures allows us to do that. So there are a bunch of different measure types. Um, Here at HealthMonix, the types that we particularly are focusing on are MIPS CQMs, eCQMs, Medicare CQMs, and QCDRs. Um, there are Medicare Part B claims measures still out there. However, these are only for small practices. There's very limited choices, and the benchmarks are simply awful. Um, so we definitely try to steer people into registry reporting. Um, the different measure types uh, for measures include process measures. Did you do the thing? Did you do the process? Outcome measures. Hey, you did the thing, but is it actually meeting the outcome that we're expecting? Intermediate outcome measures, which is a combination of those two. And there's also some lesser used measures. However, we're seeing them gaining popularity. We have patient-reported outcome-based performance measures, or PRO-PM measures. We'll see a couple of those coming in 2025. We have patient engagement or experience measures. Um, some of those are also new. And we have some simple efficiency measures. How efficient are the provider, is the provider doing the quality action in the measure? There are also different priority levels. So if there's an initiative for a certain measure, or if um, it is very important for all providers to be reporting a given measure, it's going to be stuck with that high priority tag. You also, when you're reporting measures year to year, there's always a requirement of having at least one high priority measure. So all of these factors go into the different measure types. And today we're going to be focusing largely on the MIPS CQMs, the registry measures. Quick review of benchmarking. So when you submit a measure, you'll get a met or not met status. So did you do it or did you not do it? There's also exceptions in there, maybe reasons why you couldn't do the measure. Eventually, you'll get a score. So you might get something like 80%. Now, benchmarks are graded for all measures using a decile range. And these deciles determine, okay, which range of benchmarks do you fall into? It takes 2 years for benchmarks to be created for a measure. So for example, in this year of 2024, the benchmarks were established from our 2022 measures. So it takes enough time for CMS to get enough data in order to establish benchmarks. You also, if your data is going to be taking part in future benchmarks, so for example, reporting in 2024, that data is going to be applicable to 2026 benchmarks, you need to have at least 20 instances of a measure, and you need to meet 75% threshold reporting in order to be for that data to account for benchmarks in the future. To be scored against a benchmark, you also need to meet this criteria. So both of these things are true. To be scored against a benchmark, you need to meet these thresholds. And for your data to account in future benchmarks, you also need to meet these thresholds. There are some unique measure scoring circumstances out there. And these are where you kind of look measure to measure, and when you're selecting your measures, you probably want to take a good look at these. The probably most relevant thing we're going to be talking about today in terms of point floors are the new measures in 2024 have a 7-point floor. This means you can't get any lower than 7 points when reporting a measure. Normally, for a measure, you can get anywhere between 1 to 10 points for each quality measure. But because we're really trying to, CMS is trying to, I say we a lot, but it's really CMS is really pushing this initiative of saying, hey, these measures are new. We want to make them attractive. We want to put a spotlight on these measures. So when you report new measures, they have a 7-point floor. You don't even need to meet the 20 visit threshold um, in order to hit that 7-point floor. You simply need to be able to report the measure. Similarly, second year measures have a 5-point floor. So if you're diving into a measure for the second year, you still get a minimal 5 points for reporting it in any way. On the flip side, as I noted before, if a measure is topped out, you need to get a perfect score in order to get 10 points. You need to hit 100%. Highly topped out measures, there's only a maximum of 7 points you can do, no matter how well you do. Now, it does take a few years of benchmarks data for measures to become topped out or highly topped out as providers are doing better and better on those measures. However, you might have to make that hard choice when you're reporting a measure. Are you going to do something new because you know you're going to get 7 points? Or are you going to continue reporting some measures you know that are valuable for your practice yet are topped out? Finally, there are a couple other rare circumstances. Occasionally, measures are suppressed. Measures might be suppressed sometime during the year because there may be clinical studies that have found that the measure is not relevant. Maybe a large subset of codes have been retired or are not applicable. In those cases, CMS will say, hey, this measure is suppressed. Sorry, folks, it can't be submitted for this year. That might happen once every year, once every 2 years. The more common thing for some measures is measure truncation. ICD codes, or ICD-10 codes, to be more specific, get updated every October. And because of this, some measures, there have been enough changes to a measure due to the ICD-10 codes in order for them to say, hey, these last 3 months, the measure is significantly different than the first 9 months because of the ICD-10 code changes. We're going to truncate the measure and say it's only reportable for the first 9 months. So that has happened in years past where, hey, you got 9 months to report the measure because of these ICD-10 code updates. So that is the general gist of measures across the board. We're now going to take a little bit of a look at a couple of these 2024 measures. We're also going to look at some multi-strata measures, which are, let's just say they're the most fun measures. You get measures within measures, if you like that sort of thing, which we love it. And we're also going to take a look at some measures coming in 2025. So let's take a look at some of these new measures in 2024. So here's the full list of 2024 measures. There's a wide variety of specialties hit here, from preventive care and wellness, 497, which we're going to take a deep dive later. We have some measures for ophthalmologists and optometrists. We have some measures for mental health care, measures for CVD, for ambulatory care. So there's a lot of new measures in 2024 that are trying to hit a wide range of specialties. So let's take a look at a couple of these. So there aren't that many measures out there for providers who work with patients with CVD or cardiovascular disease. So 496 is one of those. It's also a little bit rare that explicitly in the CMS spec, it has a paragraph of why this measure is important and what's the aim of the measure. So this measure was created so that 100% of eligible pregnant or postpartum patients undergoing CVD risk assessments use a standardized tool. So every single patient walking into the office should be assessed for CVD risk at least once and as needed, additional times if symptoms persist during the postpartum period. So this is important, standardization across the board. So one, this measure was created both to make sure that there's standardization happening across the board for patients, postpartum pregnant patients who have CVD risk, and also to offer an additional measure for providers who are treating patients with CVD. We included a couple measures that are out there for these sorts of patients. So you have measure 254 if you're treating patients who are pregnant, and we also have measure 436 or 438, which is about statin therapy for the prevention and treatment of CVD. A pair of measures was released in 2024. This harkens back to measures 143 and 144, where two measures are basically reported together. These are measures for ophthalmologists and optometrists, where it has to do with patients with acute posterior vitreous detachment, and that they're receiving the appropriate examination and follow-up. So both of these measures are nearly identical. We're going to be talking about strata in just a bit. I'm going to be handing it over to Tara. So when you're looking at these two measures, you're almost like, well, why are they separate? Well, there's a couple reasons why measures might be separated rather than being in a strata. It offers providers more opportunities to meet the minimum 6-measure requirement for reporting. So if you're a specialty in one of these fields, this is a great way to do so. It also is a way to split apart the data and be able to dig into it separately, get different rates, and hopefully get meaningful data through reporting. So what is the difference between these two measures? The main difference is whether a patient or not has acute vitreous hemorrhage. For measure 500, it's an exclusion, where for measure 501, it's a requirement. In short, if you have a hemorrhage, then you should have an evaluation within 2 weeks, measure 501. But if you do not, you should have a reevaluation within 8 weeks. So it's pretty straightforward. If your patient has a hemorrhage, you ought to be reevaluated within a shorter period of time than if they don't. So now we're going to dive into some multistrata measures, and I'm going to hand it over to Tara to get us kicked off there.
Great. Thank you, Josh. We are going to be delving into the idea and the methodology of multi-strata measures in the next couple slides. Over here, we have a list of approximately 20 measures that are stratified in the Clinical Quality Measure Library. These measures are slightly different because their reporting design differs from a traditional met versus not met report. Stratified measures mean that a total eligible population is sliced and diced into buckets that allow a user to look at groups of patients really at a much more granular level. Strata are very helpful in that they can help identify smaller eligible groups of patients that have and that can let you see actual gaps in care versus looking at the eligible population as a global group of people. In addition, it can also help you see different pieces of numerator actions that may need addressing. For example, measure 400 over here, the title is One-Time Screening for Hepatitis C Virus and a Treatment Initiation. So this measure has been split into two pieces. Strata 1, meaning that you're looking for that screening for the Hep C, and if Hep C is identified as positive, was the treatment initiated? So overall, the benefits of strata are looking at the groups of patients, looking at different pieces of recommended care that may need addressing. As Josh did note before, you'll see that there are 5 measures here that do have that point floor associated with them. What this means is that these measures are either new in last year or new in the current year of 2024. Measure 493, adult immunization status, was new in 2023. Being that it's a second year measure, it has a 5-point floor. And then we have 4 new measures past that, which have a 7-point floor, and those are new for 2024. It is possible for points to go beyond the 5-point floor or the 7-point floor if during final scoring there is enough data for benchmarks to be created. And then if we have benchmarks to be compared to, you are able to go beyond that 7-point floor. But that won't be known until final scoring has begun.
Hey, Tyra, quick question came across. What does point floor mean?
So the point floor means that based on your performance, no matter what your performance is, as long as you're able to report it, you're going to get a minimum of that 5-point or that 7-point added to your score. Thank you. All right, so sometimes CMS will leverage different strata for different requirements. 226, the measure 226 is preventative care and screening tobacco use, where we're looking for screening for tobacco use and if there was a cessation intervention provided. This is a highly utilized measure, but in 2024, CMS has introduced a big change. Overall, we're looking for those patients who are eligible, and we want to know if these patients have been screened to be tobacco users or not. That's going to be your submission criteria for Strata 1. This is the strata that looks at your entire population and will be used to identify if you've meet the completion threshold. Now, the second strata is looking for those patients that were screened and identified as tobacco users and if they received the cessation intervention. This is really the group that CMS wants to look at and see if we're paying attention to this group and if they're being provided the medically recommended intervention. This is the group that will be used for benchmarking purposes and you'll be scored against. Thank you. There's also a new type of reporting average that is being leveraged in 2024. It was introduced in 2023 with Measure 493, but we're seeing that the weighted average reporting design has been leveraged in more measures in 2024. So let's take a look at Measure 493 and see how the weighted average really does apply. This measure looks for 4 different vaccines: the flu vaccine, Tdap, the herpes zoster, and the pneumococcal. Let's start at the top strata, the first one. Patients who are 19 and older are required, we will report on if they've gotten the flu vaccine or the Tdap. 19-year-old patients are actually older than, I believe it's age 50, and those patients all then fall into strata 3 as well, which is they're required to have a zoster recombinant vaccine. For 2024, it is the 2 vaccines with 28 days apart. And then a subset of those 50 and older patients may actually fall into the bucket of 65 and older. And those patients are required to have a pneumococcal vaccine at some point. I believe it's 19 within the past, I forget, X amount of years, but they're required to have that vaccine as well. This is an illustration of why we need to have stratified measures. Different age groups are required to have different vaccines, and some may require more than one, and there's definitely overlap between which ones are required versus not. So once you have your strata, CMS wants to weight each of these vaccines equally, and that weight is based on if that patient should have had it or not. So to do this reporting where you have equal weight provided to each vaccine, the weighted average sums all the numerator values across the 4 strata, and it's the denominator, that's the numerator, and the denominator is going to be the sum of all the denominator values. Once we get into Measure 497, there will be a more tangible example for us to really see how that roll-up looks. And for that, I'm going to pass it over to my colleague Josh to delve into Measure 497.
Thanks, Tara. So 497 is the big boy for this year. This is the first time CMS has ever created what they're calling a composite measure. So if you take a look at the measures, or we'll just call them submeasures for 497, all of these are the highest reported measures across the board in terms of preventative care. So we have influenza and immunization, 110, pneumococcal vaccination, 111, mammogram, 112, colorectal cancer screening, 113, BMI, 128, tobacco use screening, which Tara just went into, 226, and high blood pressure screening, 236. So when we look at these 7 measures here, these measures, for the most part, have been topped out. These are measures that people have been reporting for a long time. People are doing well on them, which is great. However, because they're so prevalent, CMS was getting not as many measures other than these measures each year. You only have to report 6, and if you're just going to keep reporting the same 3, 4, 5 measures every year, the amount of data that you're getting for these other measures aren't really up to par with these preventive measures. So CMS said, hey, these are topped out, but we still want people to be able to report on them, but we want to be able to encourage people to explore MVPs, MIPS value pathways, as well as other reporting options. Let's create a composite measure. So this composite measure is treating each of these submeasures as their own strata. So each one will get their own performance rate, and in the end, all of them will be wrapped up into a weighted average similar to the measure we just saw for vaccines. Within each of these measures, they have their exact counterpart in from previous years. Another way to say that is none of these have really changed since the last time you saw them. The same reporting frequencies are present for each measure. The same age requirements are present for each measure. Everything looks almost identical, except they're just kind of patched together like a quilt. The same goes for Measure 226. Measure 226, tobacco use screening, has its own strata. So this is also the first measure that technically has strata within strata. So it's a little bit complicated. However, if you've been reporting these measures already, you likely have processes in place to take account for this reporting. So if you're going to report 497, one, you do get that 7-point floor for reporting it because technically it's new, even though these measures have been around for a while. And also, you're going to be able to compare all of these measures side by side. So in a way, it's likely going to be beneficial for 2024 to report it because you'll get a bunch of points for reporting it, and you'll get a lot of useful data to be able to view all of these measures right next to each other and see how you're doing and how they stack up. So it will take a lot to report it. We're doing our best to make it as easy to understand in MIPS Pro as you report it. And the way it's scored is this weighted average. So I'm going to send it back to Tara for this example to see, okay, well, how do we score 497 with all these measures together?
Thanks, Josh. So here we have our 7 strata or submeasures on the left-hand side, and you'll notice that there's a new strata that's called the weighted average. Each strata itself, or each submeasure, has its own reporting rate. And what that means is that in order to calculate reporting rate, you take the MET over the MET plus not MET. So each strata will have its own rate. It'll have its own completion threshold, which is based upon complete instances over total instances. However, what CMS is truly interested in is the weighted average. It is what we recommend for users is to look at each individual strata and see where they have their own gaps in care by each submeasure. So if you're falling behind in the flu strata, then you're going to want to work on getting your data in for that, or colorectal cancer. By working each submeasure, you're going to be bolstering up your weighted average. And you can see here from that weighted average that truly all it is a roll up. It's a parent strata which rolls up all the children's strata, i.e., submeasures, into one row. I do want to point out that the strata 1 being leveraged depletion and strata 2 being leveraged for tobacco cessation for performance is applied in MIPS Pro. So what we will pick the correct strata to roll into each of those calculations. So you're going to want to meet for your weighted average, you're going to want to meet the 75% completion threshold at the weighted average level. And then here we have given an example of how to calculate performance, which is the aggregation of the not met and the met into our denominator, and then the met as the numerator. Please note that the exceptions are not included in the calculation of performance. That is because people that are an exception for any said strata means that they had a reason that the numerator action was not provided, and therefore the provider or the user that's being measured upon should not be dinged basically for not having provided that numerator action. This is the same roll-up that we were talking that is being implemented for Measure 493 as well across those different immunizations. Here's just a tangible explanation regarding the composite measure. And now we have some proposed measures for 2025. The 2025 proposed rule is available. And in this proposed rule, CMS is proposing 8 new CQMs, and they're proposing to retire 11 of them. They're also proposing to add 1 new ECQM, electronic clinical quality measure, and retire 1 from the inventory. Out of the 10 new CQM and ECQM measures, we can see that 8 of them are process measures. 2 of them are patient-reported outcome measures. Measures that stood out to me in particular was the proposed COVID-19 vaccination status measure, specifically given the healthcare landscape that we have been living in for the past half a decade. Additionally, there is a new melanoma measure. Dermatologists may have struggled to report on applicable measures in the past, specifically because measures 137 and 138 have been retired. So this new measure possibly provides a specialty-specific measure to alleviate some of the reporting burden for dermatology-related specialties. I'll now pass it back to Mike to talk about some tips on selecting measures going forward.
Thank you very much, Tara and Josh. That was fantastic. And there's been some good questions, and I think we're going to have a little bit of time to go over some of those questions as well. So if you want to take this time now, it's a great time to put your questions in. So tips for selecting measures. I think this has become more difficult over the years. As Josh was saying earlier, a lot of people choose the same measures over and over and over again. And what CMS is saying is that they're not utilizing the new measures, the outcome-based, the high priority measures that they're going after. So you're going to see an increased rate of retired measures. I think over the next couple of years, you've seen it already. Some of the most popular measures that you have reported on are no longer available to report in 24 and are going to come off the books in even a faster pace in 2025. So focusing measures that align closely with your specialty, that's not always easy because there are many specialties that we run into that just don't have measures that align to the work that they're doing, and they're being asked to do things outside. Consider data volume. This is a big one for us, especially when we're looking at measures for you to report on new measures. Do you want to report on a measure that has 10,000 patients in it, or do you want to report on a measure that may have 55 patients in it? Sometimes it's easier to concentrate on a smaller measure, but be careful because the swing is much, much bigger. Stay informed, keep up with the updates and changes to MIPS measures and reporting requirements. We put on these webinars, as well as we have a lot of documentation out there around these measures on our website. You can look at every single measure that CMS has for CQMs and ECQMs, as well as our QCDR measures. Prioritize high impact measures, focus on patient outcomes and healthcare quality measures. Those have the highest scoring potential. You'll see a measure like 134 or even 130, so your depression screening or your medication list measures. Really, really difficult to score well on. But some of the outcome measures that are out there, even the high priority measures, you can score well on without being at 99.8%. You have the opportunity to score well for these measures, especially small practices that get that extra bonus. You can score very well for these measures. Optimize performance. Look at specialty measure sets. Look at the QCDR measures that we have. Ability to report through those is really great, and gives you the opportunity to prioritize those high impact measures. So those kind of work in together, and plan for long-term success. I think you'll find some of these new measures look like they're really in the direction that CMS is making us go when you're talking about kind of compiling all the data into one measure, looking at things like social determinants of health, populations that are underserved. That's what a lot of that is looking into, and I would highly recommend trying to take a look at those measures because that's what's going to be there moving forward. What's coming and how do we prepare? So limited choice opt-out measures is something that's in the proposed rule currently. CMS is planning to apply a new approach for benchmarking measures that are used by certain specialties deemed to be impacted by limited measure choice. So measures would no longer be capped at 7. You'd have the opportunity to score between 1 and 10 points. And the 97th percentile for that measure corresponds to a 7.5 measure points, giving you those who fit into these brackets that haven't been 100% determined right now, the ability to report on the measures that are the most meaningful to you and your client, your patients, but also give you the opportunity to score at least 7.5 points, where in the past, these mostly would be 0 or 3-point measures for people that perform very low. So what does the future of MVPs look like? I threw this in here because I do think that CMS is continuing to increase the number of MVPs available, really wants everybody out of traditional MIPS in the near future, and making sure that they have the available MVPs to move forward. So multiple specialty types. So building an MVP that might include, a dermatologist and a Mohs surgeon, or including a optometrist and an ophthalmologist, all in one measure calculations or one MVP, trying to keep those groups that normally work together in availability so that they can report an MVP together instead of needing to split up in subgroups. Quality measures include quality measures like the screening for depression, high-risk medications, including a lot of those measures in each one of the categories because those are the high priority measures that CMS has deemed they want to see. Include cost measures like TPCC and MSPB and all the new plans. Collaboration, so creating a bridge for clients without an MVP option until they can measure and be introduced and more closely associated with all the specialties. Basically taking a little bit of a step back and looking at making these measures available to all. There's a lot more, I would say, that's going to come out of this in the final rule, as well as even in next year's proposed rule. As you know, they're not doing away with traditional MIPS today. By as we get closer to the end of this decade, you're going to see MVPs take over and traditional MIPS disappear. The other new proposed rule thing that is going to impact performance for those that are in advanced payment programs, and particularly in this case, the MSSP ACO programs. They are planning on introducing the APP Plus quality measure set. That's going to change to only allowing them the ability to report through the collection types of ECQM and Medicare CQMs. That's a new reporting type in 2024 that's only available for MSSP ACOs, and that's Medicare. These are the Medicare savings programs that are out there. It will include the current 6 measures that are there and incrementally grow to include 5 more measures by 2028. New pathways really and kind of everything, and this is straight from the proposed rule, really pushing around how the adult universal foundation measure set is going to drive quality reporting and quality efforts moving forward, reducing administration burden because we're looking at things that make sense for all patients and better healthcare across the US. And it's going to align ACOs within the measures of MVPs. They want to start tracking and making sure that everybody is tracking the same data. Steps to 2024 reporting and preparing for 2025. Develop your reporting plan, understanding what you're doing in 2024. We're late to the ball game now. This is September. While you have all the way through March 31st to really report your data, you want to make sure that you have a plan in place now. I actually think the most proactive groups that I'm working with are already looking at the measures for 2025 and how they can implement those measures, whether that's changing workflows within your organization after looking at some measures that you may be eligible for, checking the availability of certain measures as they move forward. I think there's still going to be a bunch of measures that are going to be eliminated in 2025, and keep your eye on those to make sure those aren't measures that you're doing. Determine if you're reporting as a group or individual. There's a lot more to that, right? You could report as a group and individual at the same time and receive the highest scores. I've gone over that in a number of webinars. I think the last one was a back to the basic webinar you could take a look at. Determine if an MVP will be helpful for you. You could report an MVP as a subgroup, as an individual, as your entire group, along with traditional MIPS as individuals and a group. So you could report in a lot of different ways, and CMS will take the highest of your scores. And this could be very important because of the impact of the cost score. You could really reduce that impact using an MVP, but you could reduce it either way. It could be picking if the MVP has your lowest performing cost measure only, you could bring down your cost score rather than in traditional MIP. So I highly recommend tracking and reporting both of these scenarios. And if you haven't already started tracking your quality data, it's important to get started now. A lot of these measures have changed since last year. Just a little plug for MIPS Pro and MIPS Cost Analytics. These are our 2 products for our MIPS providers. We have best-in-class US-based support team and integration teams here to help reduce the burden of quality reporting and allow you to do what you do best, and that is to provide the highest quality of care to your patients. Taking a look at here, this is what our dashboard looked like actually last year, 2022. So I update that picture. But here you'll see we show you everything that you need, including the complete and the MET and the exclusions all across your board. Our cost category, this is an example of what our cost scoring looks like. We give access to our users through a program called the Qualified Entity Program, where we provide you not only what your MIPS cost scores look like, but also the ability to dig down into them and understand where the gaps are and what information you need added. If you have questions about either of those, you could definitely reach out to me and my team, and we can help you decide what is the best option for you. Our product and our team here help our customers have a 10% higher quality measure score than the national average. And we help one organization individually with a 63% improvement in just their depression screening in 1 year. So I'm going to hop back here, and I'm going to take a look at these questions and get that. All right. You guys ready, Tyra and Josh, for some questions?
Absolutely.
Sure.
Sure.
If you don't provide care to patients of certain age groups, does it impact your potential score if you don't have any patients in the certain age stratas? I think this question was asked during the 497 discussion, so I'm going to slide back there while you guys talk about it.
Well, the age groups I think applies more to the 493, the immunizations, and what that's going to, if you're not providing if you're not providing care to like older people, for example, that's not going to affect your score. It's that you just didn't have eligibles for that strata, and that's why we have that weighted strata at the end, because that takes it into account. And so you're not dinged for not having that age group in your patient population.
But if you don't have enough patients in your population, you can still score, or
So 493 is different than 497. 493, you're not required to have 20 per strata. Currently, we actually do have a question out to CMS to get clarification for 497. They did state that you needed to have 20 eligibles by submeasure. However, what our question to them is, does that mean that CMS is only going to count those strata that have 20 eligible per submeasure, or do you need to have 20 eligible per submeasure in order to even report the measure? Sent the question out to CMS. They've taken that question to their leads. We don't have an answer to that just yet. So when we do, we can definitely send out some communication with a clarification.
great. Another question about 497. We knew this would be the winner, right? It's the most interesting new measure that they've added, but do we still report on those measures individually as well as measure 497?
The only two measures that are available for selection are 226 and 3, the blood pressure one. You can report on both of those and the 497 composite.
Right. So the other four measures there have been eliminated from traditional MIP scoring. So
Correct.
you don't have the opportunity to do the first four measures. Cool. All right. Working my way up. All right. Well, the question was already answered. Sorry, I'm just looking through these questions, making sure I keep the screen keeps rounding.
Yeah, one additional quick thing too is I believe mammogram, colorectal, and BMI, those are also available in different MVPs. So you might see those measures pop up in MVPs as well, but you can only report them through that MVP. You can't report those individually.
Why are the number of measures that can be reported via claims decreasing every year?
I think you could answer this best, Mike.
Uh, well, it's because CMS wants to ask wants everybody into some type of program that's reporting this stuff electronically. Claims-based measures are losing out. I think, if there's two reasons. One, you have the drive that CMS is trying to get people onto EHRs. And then two, that people have done so well on these measures that they continue to top out because, you know, that's how measures are determined for elimination. So if there's a measure that has an equivalent Medicare, Medicare Part B and a CQM, what you get from those two is that they could have different benchmarks based upon the people that have reported those two measures um, in those ways through those ways. They can get different scores, and a lot of times the Medicare Part B measures, people are doing so well with them that they become heavily topped out and get rid of them. But it is a two-part question. Um, Two-part question when it comes to how CMS wants those measures taken care of. All right. If you choose to submit both traditional and MVP, if the MVP does better for PCP but better using traditional for all specialties, will CMS take the MVP for PCP but use traditional for the specialties all in the same tin? So CMS will give the highest score for every individual within your group. So if you're reporting MVPs for the entire organization or subgroups, and that same provider is also reporting individual traditional MIPS as well as group traditional MIPS, CMS will take the highest of those 4 scores, and that's combined, not just in each category, right? So it's combined, which one of those 4 are the highest scores that you'll have, and that's how that is reported. So everybody can have a different score in a different scenario when they're looking at this. So someone asked about MVPs for pathology groups to consider. I usually don't dive into specialty specific questions on the live webinar, but I think this question is a great one because there are a number of specialties, whether you're radiology, pathology groups, as well as others that aren't patient facing. Currently, they don't have a cost measure, and CMS won't create a MVP unless there's a cost measure associated with them. So you may be able to find a measure that an MVP that has only 4 measures that you can report on, and costs will be reweighted for you, but there is no specific MVP currently for any of the specialties that aren't patient facing. Someone asked a question here. We are a new small practice and we have opted out from reporting. I am not really sure how we opted out. Do you know how long you can opt out? A new practice, the opting out, I'm guessing you took one of the COVID exclusion from a previous year, or as a new practice, you're not eligible for it yet. But as we know and as we have today, that all exclusions are gone in 2025. So you are going to have to report in 2025 as long as you're eligible. There is no opting out anymore. I think that's all the questions I'm going to be able to, hold on. All right. I think those are the questions I'm going to get to today. Some of them are a little bit more in depth, and I want to make sure that I answer them correctly and have my team answer questions correctly. Please let us know if you have any other questions. Please reach out to me and my team here. You can reach me at mlewis@healthmonix.com, and I'll make myself available to answer your questions. Everybody have a wonderful week, and I look forward to talking to everybody soon. Thank you.
Thank you, everyone.
Thank you.
Thanks, Josh and Tara. Appreciate it.